Thank you very much for the kind invitation to all the organizing committee. So since it's a meeting on insulin resistance, I thought that I would focus on insulin effect on adipose tissue metabolism. And these are my disclosure for this talk. So everything that I will present has been funded by public funding agencies. So my objectives today will be to briefly review the concept of adipose tissue insulin resistance in vivo, to examine the effect of prediabetes on postprandial fatty acid flux and dietary fatty acid partitioning between adipose tissues and lean tissues. And finally, we will examine the effect of change in insulin sensitivity on postprandial fatty acid metabolism in healthy subjects. So by way of introduction, I think it's clear for everyone in this group that the classical way of measuring insulin resistance is through glucose disposal. And first, it has been done, of course, with tracer studies using whole body glucose disposal. And then later, it has been refined per organ. And nowadays, with the advance, for example, of positron emission tomography with the use of glucose tracers such as fluoride FDG, we are able to track the glucose disposal per organ, for example, in the muscle, in the liver. And nowadays, and that has been done fairly recently by the Swedish group in Gothenburg and Uppsala, we now can have measurement of glucose disposal in white visceral adipose tissue and subcutaneous adipose tissue as well. But this is relatively new. And although we now have these measurements of insulin resistance or glucose insulin-mediated glucose disposal in the adipose tissues, it's relatively new. And actually, for the last couple of decades, the metric that was used for insulin sensitivity of adipose tissue has been insulin-mediated suppression of non-esterified fatty acids in circulations. And many different index of insulin sensitivity in adipose tissues have been described using either non-esterified fatty acid levels or fluxes or glycerol level or fluxes in relation to insulin level. But all these variation of the insulin resistance definition in adipose tissue use pretty much the effect of insulin in suppressing free fatty acid or non-esterified fatty acid mobilization from adipose tissues. And everything is really geared towards this concept of insulin-mediated suppression of fat mobilization from adipose tissues. One problem with this definition, of course, especially when you look at postprandial metabolism, is that there are many pools and many different processes that generate free fatty acids in circulation after a meal. There's, of course, the intracellular lipolytic process, which is blunted by insulin, that provides the larger bulk of non-esterified fatty acid in circulation. And of course, this is readily suppressed by insulin. But there's also the other less frequently studied, but nevertheless important after a meal, spillover of fatty acid mostly from chylomicron triglycerides that get hydrolyzed. And then the non-esterified fatty acids can be, of course, trapped in adipose tissues, but can also directly spill over in the circulation and contribute to the free fatty acid fluxes after the meal, especially late after the meal, after the first 3 hours or so after meal intake. And so this process is complex to capture, and in order to take a look at these different pools of fatty acids, you need to use several tracers. And we have established with other groups as well some tracer methods using intravenous palmitate and oral palmitate together with glycerol as well, infusion rate, so that we can capture an index of intracellular lipolysis as well as palmitate or fatty acid release in the circulation, both from the total intracellular plus dietary pool and from the dietary pool specifically using an oral tracer. And in addition to that, we also now use a PET, a position emission tomography tracer, fluorothioheptadenoic acid, that actually allows us, when given orally, to track the dietary fat partitioning in the different organs of the body. And as you can see here in this first publication, when we published and validated the method, that we can track the dietary fat in the thoracic canal here. And then from there, it seeks circulation and progressively is partitioned in the different organs of the body. And using this method, we're able to recapitulate what others have found using various tracer methods. That is the density of storage of dietary fats in the intra-abdominal fat is greater than in the subacute abdominal adipose tissue, which itself is greater than the thigh or lower body subacute adipose tissue. So this is uptake per volume of fat. So there's about a twofold difference from the intra-abdominal to the abdominal subacute to the peripheral subacute fat partitioning with regards to the density of storage. And you can appreciate that obese, abdominally obese people tend to have lower partitioning per fat mass, especially in the abdominal fat region. So we have published that before. One thing that is very interesting, although, is that despite this lower density of storage, when you compare the storage per adipose site, it's almost equivalent in lean subjects versus abdominally obese subjects versus impaired glucose tolerant subjects because of the fat mass expansion that appears to compensate almost accurately for this lower density of uptake. So what we were interested to do, and we have done it and published recently this paper in American Journal of Physiology, is to try and look for the determinants of the postprandial fatty acid fluxes from the spillover as well as from the intracellular lipolytic process, and try to incorporate a measurement of the spillover on the one end, but also of fat trapping on the other end, something that has not been done before. And we compared impaired glucose tolerant subjects who are, of course, insulin resistance as judged by the OMA-ER here, which is greater. They also have, of course, higher fasting insulin and glucose levels. higher waist circumference, higher BMI, and higher fasting triglyceride levels, and compared them with normal glucose-tolerant individuals. And as expected, of course, the glucose excursion after a meal is higher with impaired glucose tolerance by definition. There's also an increase in insulin excursion as well as C-peptide excursion. This is also well expected. And as others have shown, and we confirm that as well, the free fatty acid or the palmitate rate of appearance is higher from the beginning of the meal and stays higher after in the insulin-resistant group, impaired glucose tolerance group, compared to the control group after a meal. What is a little bit more surprising is that palmitate spillover did not change from one group to the other. So didn't seem to have any defect of spillover in the insulin-resistant group. And by way of subtracting the rates by exclusion, you can see that the intracellular lipolytic process is really the source of this extra palmitate flux after a meal in those with impaired glucose tolerance. Quite surprisingly and strikingly, we didn't find most changes in dietary fat partitioning between the two groups, except a larger, an increase in dietary fat partitioning and intra-abdominal fat in the impaired glucose tolerant group, and a trend towards overall total adipose tissue partitioning of dietary fat in the impaired glucose tolerance group as well. So this came as a surprise to us, and that was not expected initially. And when we looked at the determinants, the multivariate determinants of palmitate appearance rate after a meal, we recapitulated the observation of the Michael Jensen's group that total energy expenditure is a determinant of free fatty acid fluxes in humans. And we saw the same thing in our overall population. But quite strikingly, and in contrast to what we could have expected, dietary fat trapping in adipose tissue was correlated positively and was included in the multivariate model in the end. And these are the only two variables that can explain the increased palmitate appearance rate after a meal in pre-diabetic individuals. When we look at the determinant of dietary fat adipose tissue trapping, we observe that sex, actually women stored a larger proportion of their dietary fat in adipose tissue, which was expected. Again, impaired glucose tolerance entered the model as we have seen before. Age was inversely related to this dietary fat partitioning in adipose tissue. Fat mass was directly related, which is again expected. And in contrast to what we could have expected, insulin secretion rate was actually inversely related to this partition. So we could have thought that insulin secretion could push for more dietary fat partitioning in adipose tissue, but we actually saw the reverse. And quite interestingly, we saw that triglyceride, circulating triglyceride, was a positive determinant for this trapping, something that has been observed in other studies, especially Keith-Frayne studies, before using arteriovenous gradient techniques. So this is all well, but it's cross-sectional observation. What about if we try to change insulin sensitivity in healthy subjects? And that is what we did using overfeeding for 7 days in healthy subjects. And this was published last year, again, in American Journal of Physiology. So in order to achieve that, we increased caloric fat intake by 50% for 7 days. And we increased carbohydrate intake as well as fat intake, especially saturated fat intake here, which was increased by 2-fold during the 7-day feeding process. And that was a cross-sectional, a crossover randomized study. So each individual was his or her own control using isocaloric diet or high caloric diet in a crossover study. And this is the subject. So we had 7 men and 6 women. You can see the change, no significant change in weight or BMI, but there was a significant increase in OMIR in these healthy subjects, as well as Matsuda index, which decreased. And disposition index also was reduced with high caloric feeding for 7 days in these individuals. So, however, we could not see any change in postprandial free fatty acid or palmitate appearance rates before versus after the different or in between the different diets, nor did we see difference in glycerol fluxes or fatty acid spillover or dietary fat oxidation. However, what we could pick up is a significant increase of dietary fat partitioning in subcutaneous adipose tissues, especially in the abdominal fat region after 7 days with high caloric meals. And this was also associated with a reduction in muscle fat partitioning, dietary fat partitioning, sorry, at the same time. So it seems that inducing diet-induced insulin resistance for a 7-day seems to increase the fat partitioning in subcutaneous adipose tissue in healthy individuals. And when we look at the determinants of these changes in dietary fat partitioning in adipose tissue, what was striking is that insulin sensitivity or the insulin levels were not determinants, actually. The change in these, in insulin or insulin resistance was not actually a determinant of change in dietary fat partitioning in adipose tissue, but fasting triglycerides or postprandial excursion or change in postprandial excursion of triglycerides were actually striking determinants, positive determinants of this increase in fat partitioning in subcutaneous adipose tissues of the body. So to conclude my discussion today, we can say that adipose tissue insulin resistance, as defined by insulin-mediated suppression of plasma non-esterified fatty acid flux, is confounded by many other factors than classically defined insulin resistance by way of glucose disposal. Postprandial not esterified fatty acid fluxes are further confounded by dietary fat adipose tissue trapping and spillover, which are regulated differently than adipose tissue intracellular lipolysis. And finally, intra-abdominal adipose tissue dietary fat trapping increases in prediabetes as plasma non-esterified fatty acid flux increases with obesity in proportion with increased triglyceride, circulating triglycerides, not insulin or insulin sensitivity. So I would like to thank those who are doing the work, my team here, especially Émilie Montastier and Run Zouyi, who are the postdoc and PhD student involved in many of these studies that I've presented to you today. Of course, I want to thank my many collaborators in Sherbrooke at the Molecular Imaging Center, as well as abroad. I'm fortunate to work with many bright and experimented individuals around the world, and my division colleagues who are protecting my time to do research. They're seeing patients while I'm giving talks at interesting meetings such as this one today. So thank you very much for your attention, and I'll stop there.